Hi everyone, it's Derek here from AduMed. Welcome to today's case study on heart failure. So one of the most common questions around this topic include the management of NT-proBNP results, as well as a stepwise introduction of management regarding medication. So we cover all of this and more in today's video. We've also got a link to our theory video, which contains all the theory you need to know to get through this case study. So don't forget to pause just before the end of each question, write your answer down and click continue when you're ready to move on. So let's dive straight in.
Joyce is a 67-year-old lady who presents with a 10-month history of worsening breathlessness, orthopnea, and bilateral pitting edema. She has a past medical history of type 2 diabetes, for which she currently takes metformin 500 mg. Following her appointment, she was commenced on furosemide for symptom control and bloods were arranged. These were mostly unremarkable except for an NT-proBNP, which was elevated at 667. So, with her NT-proBNP results in mind, what will be your next step in this case?
NICE guidance suggests a referral to cardiology and an echo to be seen within 6 weeks, as her NT-proBNP ranges between 400 and 2000.
So moving on, an echo has confirmed a reduced ejection fraction of 35%. She is currently on maximum tolerated dosage of furosemide, which was commenced to help her with her symptoms of significant bilateral pitting edema. Question 2. What medication will you start next in this case? The answer to this is an ACE inhibitor. NICE states in these patients to commence an ACE inhibitor with a beta blocker. However, one should be started first, and you only add on the second of the two after the patient has been stable. We start an ACE inhibitor first in this case in preference to a beta blocker, as the patient has both signs of fluid overload and diabetes. These are two indications outlined by NICE for starting first with an ACE inhibitor. Question 3. So she's now on furosemide, ramipril, and bisoprolol at the maximum tolerated doses, but she's still struggling with her symptoms. What would you do next?
The next step here will involve adding in a mineralocorticoid antagonist, such as spironolactone.
Guidance suggests measuring sodium, potassium, and renal function before and after starting, and also at each dose increment. After this step, if there is still no improvement, then you can refer to cardiology for consideration of other medications, such as your gliflozins, ivabradine, digoxin, hydralazine, and nitrites. Question 4. Joyce is now taking furosemide, an ACE inhibitor, a beta blocker, and spironolactone. Which one of these medications do not result in an improved mortality? Well, furosemide is used for symptomatic relief, but studies have not shown it to improve mortality in this subset of patients. So, thanks for joining us today. Please share this with your colleagues if you found it helpful. Don't forget to like and subscribe, as this will really help this channel to grow.